So, greetings everyone. Thank you for joining in today. And before I start, I'd like to thank CyberSight for giving me this opportunity to present on a topic that is quite commonly seen by eye care professionals across the globe. So, I'm just going to start my presentation first. So the topic for today is headaches in optometry, from routine to sinister. And my journey actually started in India, where I passed out in 2016. And I've always been intrigued with the variety of headache presentations that eye care professionals see every day. And during that time, there wasn't a guide or a kind of a battery of tests that existed. So I started my journey in a hospital setting and I worked in an institute. And after that, I worked in a private hospital in India. And currently, I work at Specsavers in the United Kingdom. And the definition of optometry says that you are a primary healthcare professional. And I didn't quite understand that initially until I started seeing patients in day-to-day practice. And I realized that actually we are the first point of contact for many patients with different visual complaints, including headaches. And it's so important for us to differentiate or understand where this headache is coming from. And that stems from very strong communication that you portray in front of the patient, and also comes with a little bit of clarity of what are the headache presentations that are commonly seen in day-to-day practice. And so for today's presentation, we are going to look at some of the cases that I have seen throughout the years. Before that, we'll just talk a little bit about some facts. Almost 50% of the population suffers with some kind of headache. So in if you imagine in a week's time, you'll actually see half of your patients will have some kind of headache, and it could be related to refractive error, it could be related to some kind of pathology, it could be related to their general health, to some kind of medication that they're using. And like I said, optometrists working in primary eye care are most often the first point of contact for these patients that are presenting with headache. So how do we differentiate, what's something to worry about and what's routine? And also, when we talk about headaches in general, nowadays, because the population in general, and especially children, are consuming and processing information, we are seeing newer variants of headache every single day. And even if we talk about a basic thing like migraines, even that is such a huge topic because there are different triggers that keep coming up every single day. And it's important for us to keep updated of what kind of trigger exists in society, in our day-to-day life, and what kind of population is affected by it, be it the young population or the millennials or the older population. And age is a great way to start. So why is this presentation case-based? So the reason is because evidence-based practice is something which is invited now. And we used to look at textbook knowledge, and whatever we see in the textbooks, that basically is the gospel for us. But nowadays people are leaning into more about case-based discussions because the reality is a bit different from what we see in or read in textbooks. And also optometry or eye care education in general is so different in different parts of the world that sometimes, like fresh graduates, even when I was in your shoes when I started out, they are kind of confused when it comes to clinical management guidelines. And this can lead to a lack of co-management between specialists and optometrists, or even general physicians, and this can be a bit frustrating for patients. So we'll try and understand that a little bit better. So that comes to our first poll question. So which of these is the most common cause of neurological disability globally? Right, so we have a good split of options here, and most of you, 64% of you, have said migraine, which is correct because migraine is very common, and a migraine can actually cause a bit of disability to the patient. And this is something that we need to identify for the patient. So we come to our first case of the day. So over here, we have a 30-year-old social media manager who comes for an eye test with many episodes of zigzag lights, half moon shaped in last 2 months, in vision which lasted for about 30 minutes, which covered part of her vision, after which she got a left-sided headache that lasted for a few hours. She also reported intolerance to indoor lighting, so she slept it off. She is worried and alarmed that she might be losing her vision. So her systemic health is good and she's not on any medications, no family history of eye disease or systemic ailments, no eye redness, discharge, watering, or any kind of nausea, and she does not wear glasses. No history of any infections or hospital visits, but her VDU use is quite high. So she is a social media manager, so she works on computer screens a lot. So her vision is great. Her pressure is also quite normal. When we look at the anterior segment, it looks unremarkable. The anterior chamber is deep, iris is flat, vitreous, there's no negative Schaeffer's. Now, negative Schaeffer's is important. Why? Because she's getting flashes of light in her vision. So we need to understand that, hey, is this something pathological or is this something related to her getting a bit of a headache? And so we need to differentiate that. Irrespective of a patient who comes with or without headache, if they have flashes or floaters in vision, or they're seeing scintillating lights in their vision, we have to do a dilated retina examination. And we did do it actually, and we found that it was unremarkable again. And even the pupils were reacting normally, and also the cover test was normal, and her eye muscles were also working properly. We did a field test as well, a formal field test, and in this case, you can actually do a confrontation test as well, which is 70% of the time it actually gives us a good amount of knowledge that, okay, are there any visual field defects that we need to be worried about? Because again, if there is a problem of headaches and the patient is having a visual field defect, now that changes the game. But over here, there's no visual field defect. That's good. Now she was referred to the GP and with a probable diagnosis of migraine. So this was a diagnosis of exclusion because we actually did a thorough eye examination and we found that actually she doesn't have any kind of, retinal abnormality. Now, she did go to the GP. She ended up going to the headache specialist as well. And we followed up with her after 3 months. And she was very happy, actually. So we were surprised to know that because the GP directed her and because she made some lifestyle changes and also dietary changes, that greatly improved her condition. She wanted to avoid taking any medications like topiramate, which is also a very common medication given for migraines, but she was getting lesser migraines day by day. And that is great because over here, we kind of signposted her to a specialist and she got great advice from them. Now, riboflavin and magnesium supplementation is set to improve migraines. So that is something that is generally beneficial for most migraine patients, not all, because we also have to identify the trigger for it. For this patient, the trigger was probably excessive VDU use. And again, regular sleep pattern and stress relief exercises, these lifestyle modifications greatly improved her symptoms. And indirectly, an optometrist could help, her get rid of the migraines or actually manage them in a way that it won't become so frequent. And slowly she will realize that, okay, are there any changes in her diet? So there are some foods which are also kind of migraine triggers, and they can range from chocolate to cheese to alcohol, also smoking. So these are the things that probably a person should avoid or we should ask as a screening question for them. Right. So we need to so there is another type of headache which is called as cluster headaches. And both migraines and cluster headaches can present with pain that is around the eye and behind the orbit. And this can be a bit of a confusing situation for us. Now, we need to understand what is cluster headache. So cluster headache is actually a trigeminal autonomic cephalgia. It is the acronym is SUM, so short lasting unilateral neuralgiform headache, which is It does not last for many hours, but it can cause tearing and it can cause puffiness around the eyes. And this can also cause ipsilateral ptosis, conjunctival injection, and lacrimation. Now, in addition to this, the cluster headache is a little bit more painful and it's restricted around the eyes. So we need to differentiate what is a cluster headache versus what is a migraine, because the management may be slightly similar, but we will understand, okay, if the cluster headache is causing any kind of lacrimation or conjunctival injection, or is actually some kind of an infection that is causing that lacrimation. So in this case, it would be a headache which is causing the lacrimation. So that is really important to know. Cluster headache also is closely related to lifestyle modification. So smoking, dietary changes that a person can make in their lifestyle, alcohol intake can also cause cluster headaches. So in addition, so that's why migraines and cluster headaches are quite similar. In addition to pain around the orbit, the migraines can also cause blurry vision, like scintillating lights in their vision. And this can occur before the headache can start. Now, there is another type of migraine which you just get the aura. So you get just get lights in your vision, but sometimes you don't get the headache. And that is also sometimes called as an ocular migraine. And as the intensity peaks, then you can get a headache or you may not get a headache. Mostly you get a headache. And this is called as a visual aura, the scintillating lights that you see. And they can last from 5 to 60 minutes. And it can also cause sensory and speech disturbances. A major misconception about migraine aura is that it must occur prior to the onset of the headache. But this is often not the case. It can happen anytime during a migraine. So this is a good acronym to remember whenever you look at symptoms which are related to migraines, but we don't know whether, is it actually a migraine or not. So PNUT is a good acronym, and this is good for primary eye care professionals, especially optometrists. So photophobia, it generally tends to be episodic, so it comes and goes in episodes, and there's usually a trigger attached to it. So it's important to ask the patient what is their lifestyle and what are the activities that they were doing before they got the migraine or before they got the headache. And the visual aura, like I said, it may or may not be present. Sometimes there can be nausea and vomiting as well because it is a neurological phenomena, so it affects the nerves, and this can cause nausea and vomiting as well. It is unilateral. It can be on either side. It can alternate, so it can be on one side or it can be on the other side. Um, very like less commonly, it can be bilateral as well. So that is a rare case. There's always an exception to a rule. And the headache will be like a throbbing kind of a headache. And because it's episodic and because you have photophobia, we can kind of confidently say that, okay, this sounds like a migraine. And especially if they are not wearing any glasses or they don't have any kind of other, blurriness of vision or, reading difficulties and stuff like that. So that was about migraines, and now we'll move to our second case. So the case is called as nocturnal pain. So over here, we have a 46-year-old female who came for her annual test with episodes of right side pain in the temple area and also behind the eye since a few months. She noticed this first when she was watching a movie. It has happened at least 8 times. She Googled and self diagnosed it as a tension headache, and she has planned to go to the headache specialist. Now, systemic health is good, and she's not on any medications, no family history of eye disease or systemic ailments, no eye redness, discharge, watering, or nausea. And the glasses, we can see that she is a hyperope. So it's plus 4.25 and plus 450. So this does give us an indication of what the anterior segment would look like. No history of any infections or hospital visits. Yeah, so over here we can see that again her vision is 6, 6, and 5. The pressures are 31 in the right eye and 24 in the left eye measured on GAT, so Goldman Applanation Tonometry, which is the gold standard for IOP measurement. We found that her Van Herrick's is quite narrow, so it's grade 1. Cornea is clear, iris is flat, and vitreous, again, negative shapers. we dilated her, and obviously we have to be careful before we dilate such a patient. Probably you can instill one drop, just to get a little bit of dilation, just enough to check the disc, because it's important to check the disc in this patient. Um, and I show you the photos. We also did her field test, and there were no defects seen. Pupils were normal. Now, this was her disc photo. So as you can see in the right eye, there is a bit more cupping that you can see compared to the left eye. In the right eye, I would say it's like a 0.65 to 0.7 cup, and in the left eye, it's about zero point 0.3 or 0.25. And this indicates, yes, there is a bit of optic neuropathy that's going on, and this is angle closure, essentially. So the patient was referred for glaucoma management. She had laser PI in both eyes. Her IOPs are stable now, and she's also not getting any headaches. So whenever we think about like textbook, right? So we say that angle closure attack. So you have like a hard eye, and you have like intense pain, and you have halos in the vision. But that's not always the case in clinical practice. Sometimes patient might get episodes of pain, especially at nighttime. So in this patient, we found that she was having pain when she was in the cinema, or probably in an area where the pupil was dilating. So that was triggering an angle closure scenario, and that was causing the pain because the pressures rise. And this is important to differentiate, because if we classify it as a primary headache and treat her, that wouldn't make sense, because it wouldn't cure her for headaches. And when we did the laser PI, then her IOPs were stable, and we followed her up, and her IOPs have been normal. So she was very grateful. So now we come to our second poll question. So which of the following ethnic groups have the highest prevalence of angle closure glaucoma? So is it Africans? Is it European descent? Is it Inuit, Eskimos, or Arab or Middle East descent? Right, so we have a good split of answers here. And over here, I like to explain a little bit about why I chose these options. So in Africans, actually, primary open angle glaucoma is most commonly seen. And actually, angle closure is seen in East Asian populations, and also Inuit Eskimos as well, because their anterior segment is narrower. So their angles are a bit narrower compared to other ethnic groups, especially when we compare it to Europeans, Africans, Arab, or Middle East. So that is why they have the highest prevalence of angle closure glaucoma. Also, East Asians, Japanese, Chinese, Southeast Asian populations also have a higher prevalence of angle closure glaucoma, because of the anterior segment, or how anatomically placed the angle is for them. So now we move on to our third case, all right? So this is a case that I actually saw earlier. In my career. And so 14-year-old male came for an eye test, complaining of frontal headaches since a few weeks and difficulty seeing the board in class. He had just given his exams. Unaided vision was 618 and 612, and near vision also was not that good. The autorefractor reading was -5 and -4. As you can see, it's quite high, so high amount of myopic correction is shown, and the retinoscopy reflex was fluctuating. So definitely there's something going on with the ciliary muscle here. We did a cycloplegic refraction with cyclopentolate, and we found that actually there wasn't any myopia. It was basically a spasm of the ciliary body which was causing this. And we checked his anterior segment, everything was fine. The pupils were also fine. Motility, eye muscles, no double vision or anything like that. So we diagnosed him with accommodative spasm, and it's also called as pseudomyopia, and that's why the word false alarm. So what we did was at that time, obviously it differs from country to country. In some countries, atropine is legally used, but in some countries it may not be allowed in a primary eye care setting. But yes, ophthalmologists can give atropine as therapy as well as for diagnosis. So atropine 1% therapy was initiated every alternate day at bedtime for the first 2 weeks, and it was gradually tapered down for 4 weeks to prevent rebound accommodation. So as we know, atropine knocks off the accommodation. We need to make sure if the patient has had any kind of side effects or his patient is having any kind of side effects with atropine, because atropine sulfate is also a bit of a stronger medication, but it does knock off the ciliary body, and in this case that's needed. At 10 weeks, refraction was repeated and the symptoms were significantly improved. Although we found very little myopia after that, so we refracted her almost after 3 months, and but the spasm had gone down, and both eye, the unaided vision was quite good, 6.6, and we after later on gave him +1 lenses for reading to relax the accommodation, because these children can have a spasm of accommodation again. They can be susceptible to have spasm of accommodation. We also advised reduce prolonged near tasks and outdoor activities and to reduce the screen time. This is important as well because excessive screen time is a big trigger for spasm of the ciliary body, and this can cause pseudomyopia. So in this case, this was the reason for the headaches, and so we managed him in our practice, and what are the other treatments? So, if you're a bit apprehensive about choosing atropine, because obviously we find that, okay, the younger the kid, probably atropine would be better to knock off the ciliary body. You can use cyclopentolate or homatropine as well, which are shorter acting, and they are better for immediate relief in moderate cases. So, not in severe cases, or if the child is quite young, like for example, if they're around 5 to 6 years old or under 5 years old. Yes, vision therapy also helps. So to train the accommodative facility, basically to control the accommodation and not allow the accommodation to go into a spasm. And it's best for students and long-term improvements. And like we said, plus lenses for near work in combination with vision therapy will be very good for long-term results. So that is something that can be done if, say, for example, there is a high near work demand. So that's for students and even for professionals, like sometimes jewelers or electricians, they are quite at near distances. So what is the role of these treatments? So cycloplegics, they basically help to break the spasm. So cycloplegics shouldn't be given for long term. They should be given for just a short while, just to break the spasm and provide immediate relief. And later on, vision therapy and plus lenses are used to rebuild healthy accommodation. Lifestyle and ergonomics and VDU use are used to prevent recurrent episodes of accommodative spasm. So this is something that we do see in practice, especially optometrists are seen, and they are quite confused sometimes because we see a refractive error and we're not able to manage that. But sometimes it's something like a hidden spasm of the muscle which needs to be managed. Now, the most popular cause of pseudomyopia is definitely excessive near work. And that leads us to our third poll question. So, which of these can be a cause of pseudomyopia? Is it anxiety, stress, head trauma, excessive near work, or all of the above? Right, so we've got our answers here, and so we have 48% who said all of the above, and all of the above is the correct answer. So if you go into literature and if you go into case reports, you will find case reports of patients with anxiety, stress, where they have triggered an accommodative spasm, and that could be some kind of activity they're doing when they're anxious or when they're stressed, and that could include excessive near work and head trauma. is also one of the causes. It's very, very less common, but it's still there. And head trauma basically affects the parasympathetic nervous system, which affects the ciliary body, and it can spasm. So it can overstimulate the ciliary body. And we have seen case reports of pseudomyopia in all three cases. So it's helpful to remember that if your patient is suffering from anxiety, stress, or if the patient has had a head trauma or has been in a traffic accident, for example, or like we discussed in the case, excessive near work. So all these reasons can be potential cause of headaches and pseudomyopia. And so we go to our fourth case. So over here we have a 32-year-old female, came for a routine eye test, complaining of random frontal and temporal headaches which are worse in the morning. And it started a few weeks ago, and it's every day. And she's also got ringing sensation in ringing sound in her ears. This makes her vision a bit blurry for a few minutes. She has been taking paracetamol, which occasionally helps. Now again, we notice that, okay, there's no, flashes, floaters, curtain, or gray patches in vision. It's important to ask these questions, because over here, we need to differentiate whether the blurring of vision or the headache is related to some kind of migraine. Is it a migraine? Or is it some kind of, activity in the vitreous? Is that causing a headache to them? Are they seeing any kind of gray patches in vision or a curtain or shadow in their vision, which again could mean some kind of retinal tear or detachment? So it's important to ask these questions. And nausea is also important to ask because it's causing ringing sensation in her ears as well. So we want to understand this a bit more deeply. She's a new mother and she's also taking care of her 6-month-old baby. Her systemic health is good and she's not on medications. So, what are the key points in history taking? So, like we said, we need to understand this in terms of LOFC. So, LOFC is a great tool for history taking, especially when you want to identify something that is beyond your routine kind of headache cause. And LOFC stands for laterality, onset, frequency, type, self-treatment, effect on the patient, and are there any associated symptoms? So let's walk through this case report because it's a great case to understand LOFC. So over here we can see it's laterality. So it's not connected to one eye. It's basically frontal and temporal headaches. So it's both sides. And we rate the headache as 7 out of 10. So it's not your normal headache. It's a little bit annoying, which can cause a bit of disability as well. Since a few weeks every day, and there's ringing sound in her ears. So associated symptoms, there's ringing sound in the ears. Type and severity, frequency, she said it's every day. Self-treatment, she's been using paracetamol. Effect on the patient, it makes her vision blurry, and it's in the morning. So that is kind of a something to worry about. And associated symptoms, like she said it's blurry vision. So you kind of summarize everything in kind of a few lines, when you use LOFC, because a great tool to understand where the headache is coming from, what could be the timing and frequency of the headache, how severe it is, and are there any associated symptoms? Because it's going to be really helpful for us to join the dots. So this was her fundus images, right? So as you can see over here, it's not a normal fundus picture. So you can ignore the shadow on the macula, but you can see the optic nerve, and the optic nerve is something that I want to show you. And we can see that there is a bit of blurry disc margins here. And also you can see tortuosity of the vessels, which again, it doesn't look normal, right? So why is this happening? So what happens is basically if there's a pressure, so there is a cerebrospinal fluid behind the eye, and if there is a pressure in the head, which is kind of putting pressure on the nerve, this kind of clinical picture can arise. So this makes us a bit suspicious that there's some kind of pathology involved. And as you know, that the eyes, the ears, the nose are kind of connected, to sometimes when people have any kind of issues with the cerebrospinal fluid, sometimes they have a leaking nose as well. So that is something that you need to keep in mind. So these are the clinical findings. So her vision is great, it's 6, 6, and 5. Pressures are also normal. Anterior segment is fine. we did red desaturation, and she did find that in one eye the color is slightly washed out compared to the other eye. So red desaturation is an important tool for if there's any kind of color vision shift or there's change in the perception of color vision. Now, we did her formal visual field test. I don't have the visual field scan for you today, but basically there was enlarged blind spots. So basically there was a swelling of the nerve here. And as we discussed, there's both eyes blurry and elevated disc margins, which torches blood vessels, and no obscure vessels leaving the disc, and no Paton's lines. So Paton's lines are basically just stretch marks in the retina. Um, and we use 78D indirect lens. So because the Van Herrick is deep, so we're not looking at glaucoma or anything like that. We are definitely not looking at migraines because there's no photophobia or anything like that. The headaches are worse in the morning, so probably a positional change is something that we're looking at, which can make the headaches worse. Now, how do we grade this fundus picture that we saw, right? So that brings us to our fourth poll question. So which of the following scale is used to grade optic nerve swelling? So is it Schaeffer's, is it Frisson scale, is it Smith's grading, or is it Spetz's grading system? Right, so we have a good split of answers again. So just to reiterate, Schaffer's grading system and Spetz's grading system are actually used to measure the angle of the anterior chamber. Smith's grading system is used to measure the anterior chamber depth. Its Frisson scale is the correct answer, all right? So what is Frisson scale? And probably you might not heard about it because it's not like a popular scale. But this is the Frisson scale, right? So you have grade 1 to grade 5 over here, and this is quite popularly used by neuro-ophthalmologists and also in hospital eye settings as well. So what's the first grade? If there's a C-shaped halo surrounding the disc and sparing of temporal disc margin, and there is a bit of a disruption in the radial nerve fiber layer, because the nerve fiber layer is that what superficially exists the disc. And if there's any kind of radial nerve fiber layer striation disruption, a C-shaped halo will be grade 1. And the grade 2, the halo would become circumferential. So if there's a swelling of the optic nerve, mainly the nerve fiber layer is affected and it causes swelling of the nerve fiber layer. In grade 3, there is obscuration of the vessel leaving the disc. So if you look at the major vessel where the black arrow is pointing towards, you'll find that that vessel has become a bit hazy. And that is because of the swelling of the nerve fiber layer and the compression on the vessels. Now, when the vessels get compressed, that's when you will find hemorrhages. So these are disc hemorrhages or flame-shaped hemorrhages, which are kind of restricted around the disc. And these are because of the pressure gradient behind the eye and within the nerve, which causes this kind of swelling. And grade 5, you have obscuration of all the vessels. So all the vessels that are leaving the disc, you basically can't really see them. They're very hazy around the edges. And this would indicate grade 5. And when do the most common conditions where we would see a disc swelling would be papilloedema, so increased intracranial hypertension, it causes this, and also hypertensive retinopathy, malignant hypertension, which also can present with very severe headache, which can be caused by raised high blood pressure. It can cause swelling of the disc. It can be unilateral or bilateral, and this is one of the conditions that we need to watch out for, because this is a red flag, and this there's a prompt referral that needs to be made in this condition. So the patient was seen as an emergency to the hospital eye service for further investigations, head scans, and treatment. Now, further follow-up revealed a diagnosis of IIH, idiopathic intracranial hypertension, mostly due to the recent weight gain. So obesity is a risk factor for intracranial hypertension. Also, if there is any kind of fluid in the head, so for example, if the mass lesion in the head, or if there's a compression of the nerve due to an aneurysm, that can also cause kind of headache symptoms, and that also warrants a neurological examination. So we need to refer this patient for MRI, CT scans, because this is something that needs to be managed immediately, because the patient can actually lose their life if not managed properly or not referred properly. Now, a lumbar puncture is used to, it's kind of a little bit painful procedure where the CSF or the cerebrospinal fluid is actually drained, you know. So the lumbar puncture is like above 200 to 50 in obese patients. That's classical clinical picture of IIH. And in addition to that, we need to, it's also diagnostic as well as it can be therapeutic as well, because if the pressure reduces, it's therapeutic for the patient and they can get rid of the headaches. And a patient might need multiple lumbar punctures because of this buildup. If it is idiopathic, if it is due to some kind of mass lesion or something like that, then that needs to be operated on as well. So optometrists need to be aware of how to manage this kind of a patient. So, for example, if someone comes with morning headaches and they have started suddenly since a few weeks, and if there's a whooshing sound in the ears, if it is causing dizziness or transient blurriness of vision, if it is causing any kind of field loss, that is a red flag. That means that this patient is not your routine refractive patient. This is a patient that has some kind of a pathology going on, probably inside the head or inside around the spinal cord. This patient can also present with some kind of recent head trauma, which has caused a hemorrhage, or they can present even routinely. Sometimes they also have a family history of probably a tumor or family history of IIH. These patients can also present. So it's important to understand that there are different kinds of pressures that affect the eye. So one is the intraocular pressure, second is the cerebrospinal fluid pressure in the head. So this is something that optometrists need to differentiate, because obviously if everything is normal but the discs are they appear blurry or they appear swollen, then something's going on at the back of the eye. So these are the classical symptoms. So we have headache. So increase in charactery was on awakening. So when there's a positional change, when the patient is waking up, that can cause a bit of a headache. Nausea and vomiting. So if there's a rise in intracranial pressure is severe, nausea and vomiting can occur because it also triggers the inner ear, which is responsible for balance, and that can cause nausea and vomiting sensation, and that can also be followed by loss of consciousness and death. So this is something that is a serious condition that primary eye care professionals should be aware of. Ringing of the ears, another word for pulsatile tinnitus. Visual symptoms are often absent, but they can have visual obscurations. Now, if you see papilloedema-like appearance, say for example, if you see that the discs are a bit elevated, and if you see that a routine examination in an asymptomatic individual. So for example, if the patient does not have any symptoms and you're seeing this kind of clinical picture, like, the disc margins are a bit elevated, but the vessels look normal. So we need to differentiate this from optic disc drusen, because optic disc drusens are basically deposits around the optic nerve, which sometimes change with time. So they sometimes grow, so these deposits grow, and they cause a papilloedema-like clinical picture. And if the patient is not having any headaches or anything like that, what we need to do is we need to photograph them again, like after 2 months or 3 months, and see if it's the same. If it's the same, then we don't need to do anything. We just need to follow them up routinely, because this is probably optic disc drusen. Now, if you have OCT in your practice, then that's a great tool, because at OCT, you can differentiate between papilloedema and optic disc drusen as well. Optic disc drusen, you would see those deposits which cast a shadow underneath. Whereas in papilloedema, you would see that the nerve fiber layer is very, very swollen, and you would see that bumpy nerve fiber layer around the disc. So that's a great tool to differentiate between drusen and papilloedema, because if there's drusen and you're referring for an emergency, that's going to cause unnecessary frustration and stress to the patient. So it's important to understand the difference. And now we come to our final case for the day. So a 56-year-old male came for an eye test with a recent history of throbbing headache to one side, along with mild neck pain since one day. The pain again was 7 out of 10, so it was a bit more. He was playing tennis when it started and might have had a fall, but he does not remember. He finds that his right eye looks a little bit funny in the mirror. He has got some one-sided headaches in the past, but this was worse. So again, we find that no flashes, floaters, curtain, or gray patches in vision or nausea. His systemic health is good and he's not on any medication. On questioning, there was an absence of sweating on right side of the face. He is a chronic smoker since 20 years. So this is something that's again, it's a bit of a red flag because he's having these unusual headaches, which are throbbing and which are quite severe. And he was playing tennis, so he might have had a fall, but he does not remember. So probably there's some kind of a blunt trauma or some kind of stretching of one side of the neck or head that's involved here. And on questioning, there was absence of sweating on one side. So this is something that's really helpful, and we'll understand why. So this is a clinical picture, right? So you can see there is ptosis on one side. You can see that the pupils don't look normal. So there is a bit of anisocoria that's going on there. And he was right in saying that the right side of his face looks a little bit funny. So what is this? This is Horner syndrome. And why is it caused? So it is caused by interruption of the ocular sympathetic pathway. Now, the classical signs of Horner syndrome is ptosis, meiosis of the same side. So that results in anisocornea. Now, why ptosis and anisocoria? Because um, this patient had a carotid artery dissection. So we did further scans for him and we found out that he had a carotid artery dissection. So the carotid artery is supplying to the oculosympathetic nerve, and when the carotid artery suffers some kind of trauma or damage, it causes swelling and bleeding and pushes the sympathetic nerves, and the sympathetic pathway is affected. The sympathetic pathway is supplying the Muller's muscle and the dilator muscle of the iris. And that is why, as we know that the dilator muscle is responsible for the pupil reactions, right? And so the nerves supply to the eyelids and the pupils and the face, they get affected. And this is why the carotid artery is affecting the sympathetic nerve, and the sympathetic nerve is causing same side ptosis and meiosis, all right? So we'll understand a little bit more about this case now. So a routine test was done. However, due to classical signs of anisocoria, ptosis, and anhidrosis is loss of sweating on one side of the face. He was immediately referred to neuro-ophthalmology for MRI CT scan and also stroke workup to rule out systemic causes. Now, topical aproclonidine was instilled, which resolved the ptosis and anisocoria. Now, the topical aproclonidine is a diagnostic test which is often used for Horner syndrome because Horner syndrome can have multiple causes. It can be due to stroke, it can be due to a head trauma, a road traffic accident. Also, sometimes if they pull their neck too much, that can also cause a carotid artery dissection, so stretching of the artery. And a right carotid artery dissection was found out in this episode. Now, why aproclonidine? So aproclonidine is basically affects the sympathetic nervous system, and it is an alpha 1 receptor. It is an alpha 2 agonist, but it also has some alpha 1 activity. So what happens, like when we instill aproclonidine, it is innervated by the sympathetic nerve to stimulate the alpha 1 receptors, and because the sympathetic nervous system is disrupted in Horner syndrome, there is lack of sympathetic stimulation, and this leads to supersensitivity of the alpha 1 receptors. And topical aproclonidine in this case causes dilation. So the reversal of anisocoria. So what will happen if we instill topical aproclonidine in the right eye? It will cause dilation, and now the right eye will look dilated and the left eye will look myosed. And this reversal of anisocoria is a diagnostic test for Horner syndrome. Why? Because first, aproclonidine affects the sympathetic nervous system, and the sympathetic nervous system, the ocular sympathetic nervous system, is affected in this case, the carotid artery dissection, because the hemorrhaging and the trauma is causing is affecting the sympathetic pathway. Now, MRI, it provides detailed images of neck arteries, revealing any abnormalities. It's good for soft tissue and vessel visualization without exposing the patients to radiation. Treating Horner syndrome requires a personalized approach because it can present in different ways, but we need to understand these features. So ptosis, small pupil, and anhidrosis is the main sign that we look for. Now, what is carotid artery dissection? So carotid arteries are major blood vessels that supply blood to the brain. Now, dissection means there's a tear in the inner wall of the artery, and this causes the blood to leak between the layers and create a blockage. Now, next to the carotid artery, there is a bundle of nerves, like I said, the sympathetic nervous pathway. These nerves control the pupil size, eyelid position, and also sweating. And these artery walls presses and damages these nerves. And this causes ipsilateral Horner syndrome. So this is basically the mechanism or pathophysiology of Horner syndrome. Now, this is a bit of statistics to analyze because Horner syndrome is not straightforward in all patients. So it is estimated that 25% of patients with carotid artery dissection experience Horner syndrome due to the damage of ocular sympathetic pathway. So it's basically a diagnostic for us. Up to 56% patients with carotid artery dissections can experience cerebral ischemia and in the form of a transient ischemic attack or stroke. So mind you, these patients already have headache, but these are the additional findings that we are seeing. In another study, 28% also suffered from transient monocular visual loss due to ischemic optic neuropathy, and 16% experienced scintillations that were thought to be due to acute choroidal hyperperfusion. Of these patients who experienced monocular visual symptoms due to carotid artery dissection, 36% subsequently experienced a non-reversible ocular or hemispheric stroke. So if timely intervention is not done or we've not referred them to the stroke clinic, that can cause irreversible vision loss. Now, in this case, fortunately, there wasn't any vision loss. So it's just because he found that it looks a little bit funny. That's why he came to us. And we found out that, yes, there was a Horner syndrome and we could save his vision and also prevent a further stroke. So even a mild neck trauma in a patient with ipsilateral pain, monocular visual symptoms, or Horner syndrome should trigger further evaluation because the early diagnosis and treatment of carotid artery dissection can potentially prevent permanent deficits. So that's why it's important, that we immediately refer Horner syndrome as an emergency. So this is basically an outline. So we as optometrists, we do not treat stroke or even Horner syndrome. We help in diagnosis, we help in referral. This is an outline of what treatments are used by the stroke specialist or the GP. So blood thinners are used to prevent the stroke. Regular follow-ups are done with CT and MRI scans, and also stenting might be required to kind of stop the blockage of blood flow. So that brings us to the end of the cases. So now we look at headaches and kind of summarize and understand that how we can modify our history and symptoms, how we can modify our workup, especially the questions that we ask the patient about their lifestyle, and to identify whether it's a routine or a bit of a sinister kind of headache. So, like we said, migraines with or without visual aura, there should be photophobia, one-sided typically, pulsating, nausea. It may or may not present with nausea, and there's usually a family history of migraine and scintillating lights or zigzag lines in their vision. So that typical features of migraines. Now, migraines is a huge topic, and there are different types of migraines and due to different triggers, and it can range between age groups as well. So it's important to ask, firstly, identify what kind of age group it is and then go for it, because sometimes we need to understand, okay, where did the headache come? What were you doing before, the headache? What were you doing one day before you got the headache? We also need to understand the age of the patient, especially women. So if there is, sometimes it's around the menstrual cycle that they're getting migraines. So we need to ask them, okay, when did you get the migraine? Did it coincide with your menstrual cycle or not? This will help us identify whether it's a visual complaint or basically related to migraines or not. Um, on the contrary, if there is a mix of flashes and floaters in vision, the high headache can be due to trauma or it can be a coincidence. So we need to dilate and check the retina as well. The other type of headache is, which is quite common. So migraines and tension type headaches are very, very common. We need to understand the characteristics of migraines and tension type headaches because almost 50% of headaches that I have seen are usually like migraines or tension type headaches. And tension type headache is also bilateral. It's episodic. It usually has a trigger attached to it. So it usually, if the patient is anxious, stressed, hunger, if say, for example, they've not slept, this can trigger a tension headache and it also can trigger a migraine as well. So it's important to identify, okay, this a migraine, is a tension type headache. And then we come to cluster headache, which we've also discussed a little bit about. This is also unilateral. It causes nasal stiffness and puffiness around the eyes with occasional tearing. And this is quite common in smokers as well. Also, it's common in people who take a lot of stress or are quite anxious. Now, temporal arteritis is a sinister kind of headache, which is very, very important to diagnose. So the keywords are if there's an elderly patient and they have a one-sided pain and the scalp looks tender. So it's basically the temporal artery, which is kind of triggered. It could be due to some kind of a stroke or some kind of inflammation, which is causing that one-sided ache. And it could also cause jaw claudication, so pain while chewing, and sudden loss of vision or blackout of vision. Now, this is classic temporal arteritis, and it's again, this is an emergency. It's a red flag for us to refer to the stroke clinic and also potentially to an ophthalmologist to manage and monitor the patient. This patient will also require a thorough systemic workup and may also require medications as well. Painful Horner syndrome is something that we discussed in the case. So sudden headache, unilateral miosis, ptosis, and anhidrosis are classical signs of Horner syndrome. Internal ophthalmoplegia. So again, if you see a patient, unilateral dilated pupil without any drops and just sudden headache, again, internal ophthalmoplegia is because of the compression of the third nerve or aneurysm of the third nerve. And this is again a red flag. It's an emergency. You need to refer them immediately to the stroke clinic because this patient might be having a stroke and he can lose his vision and potentially also lose his life as well. So internal ophthalmoplegia is usually affecting the third nerve, which kind of supplies to the iris muscle as well. Trigeminal neuralgia, this is again quite commonly seen, a stabbing pain around the temple or around the orbit, lasting a few minutes with a jolting and is triggered by chewing. Now, if this patient is not elderly, they're kind of a young patient, then we can suspect trigeminal neuralgia. And trigeminal nerve is a very important nerve because in cluster headache, in migraines, in trigeminal neuralgia, the trigeminal nerve is also affected. So it's kind of a trigger point for many patients. So basically, if we kind of have to categorize all the kind of headaches that we are seeing, and if we had to divide them as routine, urgent, and emergency, how would we do that? So this is just a summary of different kind of headache presentations that I have listed down over the years. So this includes optometry presentations as well. So as you can see in the routine type, we have migraines, we have tension type, we have a retinal migraine like we discussed, cluster headache, uncorrected refractive error or pseudomyopia, convergence insufficiency, convergence excess, divergence insufficiency, decompensated phoria also can cause headaches. Accommodative dysfunction, any kind of accommodative spasm or dysfunction can also cause headache like infacility. medication overuse, sinusitis, which is typically around the sinuses over here. So when you apply pressure over here, it feels a bit better. And it's usually if patient has had kind of a viral infection or they've had hay fever, sometimes people get a sinus headache. Substance abuse or withdrawal, example, even like caffeine, withdrawal of caffeine can also cause headaches. These are all routine kind of headaches because these headaches are not life-threatening or sight-threatening. Of course, when we look at the optometric management, it's usually doing a cycloplegic refraction, doing a binocular vision assessment, so doing NPC, NPA, your near vision, your distance vision, refracting them properly, and measuring the ACA by ratio. These are the things that in a refractive sense will be very, very helpful to kind of manage your routine headache presentations. Urgent, so like we discussed, acute angle closure, post-traumatic headache, so any person who's had an injury, trigeminal neuralgia, again, we discussed about that. So any kind of systemic infection, also patients who are suffering from chronic illnesses like cancer, any kind of management or any kind of chronic kidney disease or gastrointestinal diseases can also lead to headaches. This could be due to the systemic condition. Also, fibromyalgia is one of the things that can cause headaches as well. The other thing is anterior uveitis. This can cause kind of photophobia and pain around the eye, which is causing also a bit of a red eye, so circumciliary congestion. Third nerve palsy with headache. Again, we have to understand if there's a dilated pupil or not. If the pupil is not dilated, then it's probably just the third nerve palsy. It's called as an external ophthalmoplegia. If the pupil is dilated, then it's an internal ophthalmoplegia. So that is more sinister and it requires emergency referral. Headache with transient vision loss or suspect ischemia. Obviously, if the patient is doing some kind of activity which is causing kind of an blackout of vision or transient blackout of vision, that is a red flag as well. So this patient will need urgent referral to the GP as well, just to check out their systemic health. But if it causes any kind of headache or transient vision loss in an elderly patient with jaw claudication and also temporal artery, then it's an emergency. If you're suspecting a subacute mass lesion or tumor, so for example, if you see a patient and they are getting morning headaches, but apart from that, you do their visual fields and the visual fields are normal, but this seems to be unusual. So that would be again urgent referral because probably it's too early for us to say that, okay, is this something due to a tumor or not? So they will have to have some scans done anyway. So that is something which is a red flag neurologically. Now, emergency, any kind of suspect intracranial hypertension, so like we saw in the case, a subarachnoid hemorrhage, so hemorrhage which is causing a thunderclap headache. So if a patient comes to you and says that I've had the worst headache of my life, and that is instantly a red flag. If it's an elderly patient and if they've had the worst headache of their life, even if it's the patient is not elderly, they're middle-aged and they're having the worst headache of their life, that is an emergency right away. Hypertensive emergency, usually a sudden headache, which is due to a raised high blood pressure. So because of that, they can have a headache, and usually if it's affecting the eyes, you will see bilateral disc swelling as well. Pituitary apoplexy, this generally is because of swelling of the pituitary gland, which is very close to the optic chiasm. So that could cause a bitemporal field defect. And so in this case, you should do a field test just to rule out any kind of field defects, and that would strengthen your diagnosis. So any kind of headache which is coming with field loss, you have to refer them immediately. Venous sinus thrombosis as well. If the sinuses are affected, it can cause a thrombosis, and thrombosis also can cause compression. Compression can cause headaches. Internal ophthalmoplegia, like we discussed, unilateral dilated pupil can present with third nerve palsy as well, or without third nerve palsy. Either case, it's an emergency. Painful Horner syndrome, like we discussed, is an emergency. So what are the questions that we need to ask? So we did cover that in our cases, but just to kind of summarize, These are the questions. So, any kind of eye pain or redness, any recent head or neck injury, change in pupil size like anisocoria, flashes or floaters in your vision, double vision, sudden onset double vision is a red flag. Changes in visual field is also a red flag. Blurred or blackout of vision is a red flag. Nausea or whooshing sound in the ears, again, like we discussed, it shows that there's something going on with inside the head. Eye pain or redness, so we will come to it. There's another classification that I will be showing you, so you can screenshot this. So this is kind of a rudimentary classification, but this is for optometrists just to understand that, okay, if there's a red eye with headache and a quiet eye with headache, what could be the probable, diagnosis? And how do we get into identifying the signs for it? So if you have a red eye with a skin rash and they're having tearing and lacrimation and also red eye, you're probably, if there's obviously Hutchinson's sign, so you're seeing the lesion on the tip of the nose, there's something like herpes zoster ophthalmicus, which could be the case for this patient. So any kind of skin rash, it kind of raises a red flag for you. Now, if there is any kind of thyroid eye disease or orbital inflammation, there could be proptosis. So if there's proptosis, then you're probably looking at swelling of the musculature around the eyes, and that could be indicate thyroid eye disease, or that could indicate orbital inflammation as well. So like we saw in COVID as well in India, we did see that people were getting fungal infections. So in the inner canal of the nasal cavity, because of the oxygen supply through the tubes, they were getting a fungal infection, and the fungal infection was spreading all over, because obviously the ear, nose, and throat are connected, and was spreading to the eyes as well, to the extent that sometimes they had to have enucleation done because the black fungus was not reacting to or steroids. And so we saw that during the COVID infection where people were given a lot of oxygen therapy. So yeah, proptosis is a big red flag for us. If they have a mid dilated pupil and they're seeing halos in their vision, probably that with headache, and if it's a red eye, then you're probably suspecting angle closure. Because what happens is angle closure, because the pressure gradient inside the eye, the pupil does not react very well, and that causes that mid dilated pupil kind of so it's like a sluggish mid dilated pupil, and people will see halos of light, and also in kind of dark rooms, they kind of get this headache, and that indicates like an angle closure attack. If there's an irregular pupil and there's a hazy iris and there's flare in the anterior chamber, then that's straight away iritis. That can also present with a headache or pain around the eyes. Obviously, we forget that the eyes are embedded into the skull. So some people may say that, okay, I have headache, but it actually can be a pain around the eyes. Episcleritis or scleritis can cause redness with pain and also nodular appearance of the sclera. So if there's a nodular appearance of the sclera with conjunctival injection, then you're suspecting episcleritis. Now, for example, if there's a quiet eye with headache, then what are the different possibilities? So if it is like we discussed, if it's an elderly patient and sudden vision loss and temporal pain, tenderness of the skull and jaw pain, then you're suspecting AION or giant cell arteritis. If it's a cluster headache, there might be some watering, there might be puffiness, but they may not be red eye. And these people sometimes wake up with a headache, at the middle of the night. And this can be classified as a cluster headache. So that's a possible cause. If there's a young patient and they have RAPD and also color vision loss, so washed out colors, like we said, red desaturation or color vision loss on Ishihara, normally textbook tells us that optic neuritis is pain on eye movements, but that might not be the case. They may present with headache or eye pain as well. If there is an acute onset diplopia, say for example, if the patient has come in and you see an esotropia or an exotropia, unilateral, and this is causing double vision, or if the eye is up and in, we are suspecting a third, sixth, or a fourth nerve palsy. Bilateral disc swelling, like we discussed, it could be intracranial hypertension or malignant hypertension. So these are the final takeaway tips for eye care professionals. So looking at patient symptoms as a whole and knowing other headache subtypes will help the referral process for us. There is actually a source. It's called the Complete Headache Chart by National Headache Foundation. It's a valuable, quick guide to refer. So if you search Complete Head Chart by National Headache Foundation, it will show you all the headache types that are listed in neuro-ophthalmology, in optometry as well. So they've covered a wide range of headaches. We need to remember to identify the red flags, and that can sometimes save a person's life. So optometrists are not just eye care traders, but they're also healthcare providers, and that's what will differentiate from you from the mainstream opticians, because healthcare and being the first point of contact for patients will really be beneficial. To you as a professional. It'll help you grow. It will improve your knowledge. So for example, even I have always looked at clinical signs and symptoms, and this is how I've kind of articulated these cases, which I've seen throughout hospital settings. I've seen them in high street opticians as well. So these kind of patients can come to you at any point in time and at any place. So optometrists should be well equipped. So this is our final poll for the day. So I know it might be a bit overwhelming for some optometrists, but you could just give your feedback, and that would really help us. So how confident are you in dealing with headache subtypes now? So that's good. 51% of you have said very confident, which is really good. It means that you have taken away something from this webinar, and hopefully, if you go on to the internet and look at Google as well, you will see a lot of case reports of headaches in ophthalmology, and see some of you have also said fairly confident. So that's also a good sign. It means that you can actually identify the symptoms of headache and what are the red flags. So these are my references, and you can feel free to screenshot this, and you can go into the different articles that I've seen, especially in Horner syndrome. We can look at some of the questions now. So many patients come to us with severe cluster headaches, watery eyes, halos around eyes, and other treatment. What should be the treatment? So first of all, this patient should have a thorough eye examination just to rule out if the halos around the lights are due to something going on with the pressure of the eye or with the angle of the anterior chamber or not. And then this patient needs to be referred to the GP to have a systemic evaluation, and subsequently they need to be referred to the headache specialist as well. Also, we need to make the patient aware of any kind of lifestyle triggers. So like we discussed, alcohol intake, smoking, dietary, any kind of diet that they're following, or they've changed their diet slightly, or they're taking something excessive, caffeine intake. These are kind of triggers. Lifestyle modifications also are triggers for cluster headache, because it's basically a neurological trigger, and any kind of lifestyle changes can have an effect on you neurologically. So this is something that is important for optometrists or any kind of eye care providers to be aware of. So someone has asked, how about vertigo? So vertigo, yes, it's something that is the irritation of the inner ear. So it affects the balance, because the fluid in the inner ear, which is affecting your balance. And vertigo should be investigated. So this patient definitely needs to be referred to the neurologist to have a head scan done. So why is headache worse than hyperopia during near work? So what happens is, because of uncorrected hyperopia, it's easy to remember that, okay, if there is hyperopia, probably the power of the eye is less. So the eye has to work harder to focus, because you need a plus prescription. So if that plus prescription is not there, the power of the eye is lesser. And so the eye muscles have to work a little bit more to kind of overcome the near point of accommodation. And so the eye is accommodating more. And because of this, the eye is causing stress to the eyes, and this can cause headaches, or typically frontal headaches. So differentiate headache due to migraine versus acute angle closure glaucoma. Angle closure glaucoma is very important to do Van Herrick technique, and also potentially gonioscopy as well. And if there are narrow angles, or if the pressure is high, then you're looking at angle closure glaucoma. And also you can look at the disc as well to see if there's any kind of cupping present there. So could you please explain the pathophysical mechanism of which migraine, particular migraine with aura, may increase the risk of ischemic stroke? Additionally, what are risk factors that may compound the risk in migraine patients? So no, migraine is a separate category. It's not entirely related to strokes. People with migraines are at risk of having strokes. That's not something that's relevant to migraines, because the strokes are generally, they are like sudden, and usually there is a field loss when it comes to, there's a homonymous hemianopia that you see with field with a stroke patient. So it's different from migraines. So can you elaborate? The location of the headache gives us idea about its cause. Headache in which part is common in eye-related issues. So location of the headache. So most commonly, which are seen in optometric practices, are frontal headache and headache which are around the temple. This location is very, very characteristic. So for example, if it's like one-sided headache, or if it's like bilateral posterior headache, then it is sort of a primary headache, or it can be a secondary headache if there are other pathological signs, like you see giant cell arteritis, you see like a temporal headache with jaw claudication. Can cyclopentolate be used to instead of atropine to treat accommodative spasm? Yes, it can be used, but the effectivity might be a bit lesser depending on the age of the patient. So if the patient is slightly older, yes, you can use cyclopentolate. Nowadays, almost each and every student is complaining of migraine. What could be the cause and how to manage? So nowadays, we are seeing that video use, specifically gaming, has become quite popular, and that we are seeing that that's triggering a lot of migraines. So that lifestyle modification is important. If we encounter someone with GCA as well as emergency referral, should we start them on steroids? So we need to send them to the stroke clinic, and optometrists in some countries are not licensed to prescribe steroids. So you will need to check with your clinical management guidelines if you're allowed to prescribe steroids, or else you need to refer to the ophthalmologist who can prescribe steroids as well. So yes, ophthalmologists can start steroids. So please explain the photo in the last case. So the last case, you could see that the right eye, there was a ptosis. So there was a droopy lid in the right eye, and there was anisocoria. So the right eye had a meiosis, and the left eye was a normal pupil. So if there is ptosis and meiosis and anhidrosis, so there was loss of sweating on one side of the face, that is typical to Horner syndrome. So you mentioned something about prescribing atropine for those with accommodative spasm. Is it 0.01%, right? So atropine is available in 1% as well as 0.1%. So if you're dealing with someone with severe accommodative spasms, if you see the level of myopia is quite high, you can do atropine 1% as well, but we need to taper it down. And we need to follow them up after probably 10 weeks as well, because we need to understand if they are having any side effects of atropine or not. So there should be a close follow-up if you're increasing the concentration of atropine. So what is the management for patients with runny nose and hazy sinuses, as they have eye pain but not true headache? Fundus normal. So this is probably something to do with sinusitis. So this is triggering the sinuses, and this patient needs to be sent to the GP to manage the sinuses, and potentially they can be sent to an ENT specialist as well if they need any kind of scans to be done, or if they need any kind of surgical treatment for the sinuses. Sometimes the sinuses are a bit narrow. So management of Horner syndrome. So the outline of management is blood thinners. Can be carotid artery stenting can be done as well because there is a blockage in the artery, and the artery basically is in trauma, so it can compress the sympathetic nerve, and this is why you're getting the Horner syndrome. This can be potentially life-threatening as well. So it's important that a CTA scan or MRA scan is done in the follow-up as well to manage that. And if it is getting managed with blood thinners, and if the systemic health is good, then the patient is not at risk of stroke. Otherwise, they might require stenting. Yes, so someone has asked, what is the role of neuroimaging? So neuroimaging is used to image the head and around the neck, okay? So depending on what you're seeing, you will have to send for some kind of scans, right? So usually you have CAT scan, which is used for any kind of suspicion of hemorrhage. If there is a bony issue, if there's a kind of a fracture that you're, or a trauma or a fracture, then again, a CAT scan is quite helpful. MRI is also very good, which is helpful in tumors. It is helpful in vascular anomalies. It is helpful in inflammations or inflammation of the meninges. It is helpful in AV malformations. It is causes it also like lesions that cause inflammation. MRI is very helpful because it kind of shows up the soft tissues very well and also can suggest any kind of systemic issues as well. So that's really good. And any kind of vascular abnormalities like venous sinus stenosis or venous sinus thrombosis or even IIH, the MRV and CTV is quite helpful. And then you have MRA or CTA, which, like we said in Horner syndrome, it is used for any kind of dissection or any kind of aneurysm which is around the head or the neck. So LOFC is basically, it stands for laterality. So what side of headache you're getting. Then onset, so when did the headache start? Then frequency, how often you're getting the headache. Then type or severity. So rate the headache from 1 to 10, how severe it is. Then self-treatment, it means T stands for self-treatment, means that have they used any kind of medication to self-treat themselves or self-diagnose themselves, and effect on the patient. So what effect is it having on the patient? Is it affecting their lifestyle? Are they able to do something? Is it getting triggered by activity? Is it getting better with activity? Do they do something which makes it lesser? Are they sleeping it off? What are they doing? So that effect on the patient. And then associated symptoms. So for example, blurriness of vision or nausea or vomiting along with the headache, or any kind of redness or lacrimation, where the patient might not present with a red eye, but they might say that when I get the headache, I get, a red eye and lacrimation and watering. So then that could indicate like a cluster headache. So it's important to ask LOFC because it gives you a good insight on when the attack happened and what happened or what the patient went through. It's really important. I would like to thank Cybersight for giving me this opportunity to present my work around this topic. And a big thanks to the audience as well. You all have been really attentive. It's really nice to know if, optometrists are part of this webinar as well, because optometrists are often not very confident on clinical cases and how to diagnose clinical conditions, be it headaches or red eye or watery eye. And so it's important that optometrists, being primary eye care health professionals, are equipped with the skill set to manage these conditions and also refer if they are not able to manage them.